Okay, perfect. Here we have a very simple topic, actually, um, which is the primary prevention of atherosclerotic cardiovascular diseases. Okay, what do we mean by the atherosclerotic cardiovascular disease? Yes, I just asked about that. What are exactly the diseases included in the atherosclerotic? Yes, any idea? Do we have any idea about that? Hmm. What we can say about the atherosclerotic cardiovascular disease?
Just to give him a statin and dyslipidemia. We're gonna talk about dyslipidemia.
Okay. MI, yes. Hypertension, no. No. Hypertension, no. Hypertension is cardiovascular disease, but not atherosclerotic cardiovascular disease. Okay. One more. Hello? Hello?
Yes, sir.
سامعني?
Yes, we hear
Okay,
you.
very good. Okay, so my friends, what do we mean by atherosclerotic cardiovascular disease? Okay, like mentioned here, this type of diseases could affect the heart or the brain or the periphery. It's caused usually by the occlusion of the arteries. Okay, in terms of the level of the heart, it will cause the angina or the myocardial infarction, for example. Both are caused by the atherosclerosis. In the brain, it, it could cause ischemia, which we call TIA, transient ischemic attack, or even the stroke. It could cause a stroke as well. Okay. In terms of the periphery or the limbs, it could cause intermittent claudication, which is caused mainly by the arterial occlusion of the legs or of the legs, yes, usually in the legs, but it could happen as well in the arms. Okay, so mean atherosclerotic, we have stroke, we have TIA, angina, myocardial infarction, claudications. What that could be caused by a result. الو
Yes, sir.
طلعتني ارميا ولا ايه؟
No, sir, I am hear you. But you're
Kick me out, right?
me? No.
It's not you?
Yes, not me.
Okay, I forgive you. No problem. تمام. So, did you hear me, right? Did you hear me when I was saying
Yes, sir. Yes, sir.
sclerotic? Okay, so this is what we mean by
No.
the
No, we didn't hear you. I think we reached to the intermittent claudication.
Oh, yes. Oh, that's it. This is the final thing. So, atherosclerotic cardiovascular disease is whichever disease that could be caused or could be a result of the atherosclerosis or the arterial occlusion, like the angina, like the myocardial infarction, TIA, the transient intermittent attack, could be even the stroke, intermittent claudication, and etc. Okay, that's it. Perfect. So here we have some notes. I summarized. Eamon, did you get it or no? VTE? No. No. VTE? No. Venous thromboembolism? No. It's not atherosclerotic cardiovascular disease. Okay. Because VTE is caused by the like the a cause of the clotting or the thrombosis, a cause of the like a result of the thrombosis or the clotting. It's not because of the atherosclerosis. It's not due to the fat precipitation in the arteries or the lipids precipitations in the arteries. Okay, so yes, we have here some facts about the from the Canadian Heart Association. Yes, you will find some statistics here. It would be fine to read it to know how impactful is the cardiovascular diseases in Canada. Okay, perfect. Yes, here we have the risk factors for the atherosclerotic cardiovascular diseases. We have some modifiable and non-modifiable cardiovascular disease. Okay, we have diabetes, dyslipidemia, hypertension, and etc. We have age, family history, male, and we have other factors like the HIV, if the patient is taking retroviral, retroactive antiviral, chronic kidney disease, liver duration, etc. Okay, here we go. Let's complete this part together. Okay, this part to be completed together in few seconds. I think it will be easy. Okay, we have to complete the screening age, at what age we will screen, and what are the parameters, what are the tests, and what are the frequency. Okay, after how many years we have to repeat the exam or that. Okay, for diabetes, what are the screening age for the atherosclerotic cardiovascular diseases?
40.
Yes, exactly, 40 years. Perfect. Parameters, what we test. Hmm.
Just for the diabetic.
Yes,
After
diabetes.
after yes, after 40
Lipid
after
profile.
For diabetes, we test lipid profile. I'm
No,
talking
sorry.
about
HbA1c.
yes. Hmm. Fasting blood glucose, right?
Yes.
That's it. It will be sufficient. Okay. So at 40 years old, for what are the frequency to repeat the test?
every 3 months.
No, Eamon, we are testing the risk factors. We're screening the risk factors. The risk,
Every 3 years.
yes, every 3 years. Perfect. Very good. Okay, for diet, what are the screening age for diet? If you are going to check the diet, do we have a specific screening age?
No, I think no.
Yes. No.
Even if he is a child, he has to be okay with that.
And if you have recommendation for diet, we can say what would we say? Recommendation for diet. You know the recommendation to prevent the
DASH diet.
DASH diet. What else?
Sodium.
Low sodium, high potassium, low
Yeah,
fat.
low
The
fat.
DASH diet. This is the DASH diet. I
What
just
are the
make it in
recommended?
details.
Do you remember the recommended for the maximum fat intake per day?
300 milligram reduce
Yes, for primary prevention, it's 300 milligrams.
and 200 for secondary.
200 per second. Yes, yes.
Yes.
Okay, that's it. For that, yes. For other types of that, yes. For alcohol, it's recommended to decrease the alcohol consumption, and for the increase like the omega-3 intake, maybe pistachio and other nuts, all will be recommended. Okay, very good. For dyslipidemia, what are the screening age?
40.
No, 45 for men and 45 and 55 for women. More than or
40 years.
For dyslipidemia, Armin, it's 40 years. It's not 45.
okay.
It's 40 years. Yes. Okay. Tests. What are the tests?
LDL, HDL,
LDL.
Yes. The most important is
LDL.
LDL.
what is the target?
Oh,
What is the target for the LDL?
Not
Less
more
than two?
than
Less than
not
2.
more than 3.
Less than 2.
Oh, okay. If you are
No, no.
treating LDL for a patient, what would be your target? If you have a patient that you need to treat him, his LDL is 4
My target is 2.
or 4.5. 4.5 or even 5. Let's say his LDL is 5. What would be your target?
50% decrease or decrease than 2.
Yeah.
Less than 2.
Yes, exactly. Exactly. Okay, less than 2 or even 50, more than 50% decrease. Okay, what are the frequency?
Every 6 months.
6 months. We repeat
3 months. 3 months.
3 months.
Yes, I think.
3 years.
سوف لا أتحدث.
It's 3 years, my friend.
وانا
You
كل ما
will
اقول
test
مصر
him. You will test him for lipid profile every 3 months. It will be
okay.
no, every 3 years. 3 years on. Okay.
for
Hypertension.
LDL, when the patient consider has dyslipidemia, I don't get it.
Decrease
Above,
what?
when he consider he has dyslipidemia above 3 for LDL,
For diagnosis, you mean?
yes.
It's above 2.5 or 2, I think. 2.5 usually.
Okay.
2.5, he has to be, he has to get, yes, pharmacological approach, as much as I remember. But 2, usually below 2 is that, usually this is the target.
Okay.
Okay, for hypertension, what are the screening age? Fast.
40.
40 for hypertension.
Yeah.
Okay.
Yes, for me, yes. 40.
40, yes. It's 80 years.
18.
Yes, 18 years. Okay, for hypertension, it's 18 years old. Okay, what is the parameter? It's blood pressure, as we say. Okay, frequency. At what frequency should we test the blood pressure? Every 5 years. Correct. 5 years.
I think annually.
Every visit.
Wow.
It's in every visit. Lack of physical activity, yes, for all age, at all ages. Okay, you have to recommend physical activity and etc. Parameters, what are the physical? Yes, 150 per week. Frequency as well, every visit. Okay, smoking, at what age? Smoking and obesity, at what age?
All
No
ages.
age.
Hmm?
All
All
age.
ages.
All age.
All age.
Thank you.
Okay. And frequency. Frequency. بسرعة.
3 months. 3 months.
6 months.
Okay. Obesity as well, the same thing. Okay, every visit. Yes. Okay, age. What is the risk age? Non-modifiable. Here we are talking about the non-modifiable risk factors. Okay, what are the risk age?
Above 55.
65 and a half.
Above what?
65 and above.
For women, 65.
Okay,
And
65
male,
for
65.
65 male, 65 female. Okay, yes, exactly. 65 female, 55 male. Family history of premature cardiovascular disease.
But excuse me, 55 male and 65 female for premature cardiovascular disease, not general, or it's general here.
It's general. It's general, not for premature. For premature, at what age? What
For
age?
45 male, maybe 10 years less, and 55 female.
Yes. 45 male, 55 female for premature. Family history of premature cardiovascular disease. Okay, that's it. And male sex as well, yes. And we have other risk factors like First Nation, South Asian, inflammatory, etc. It would be fine to read them. Okay, so here we have a list of risk factors, screening ages, parameters, and frequency, and etc. Okay, the age, starting age is important, I think, I believe. Okay, so
Doctor,
do we
doctor,
have
sorry,
any
doctor.
risk
Can, sorry, yeah. Yeah, can you, yes. One moment, please. I'll take a picture. That's it.
سكرين شوت؟ انت بتاخد سكرين شوتس ليه يا جدع؟
عشان بنزلها عندي بعد كده على طول.
ماشي.
تذكار يا ريس، تذكار.
تذكار سعيد ان شاء الله. Happy New Risk assessment tool. Okay. Do we have any risk assessment tool for cardiovascular diseases, atherosclerotic cardiovascular diseases?
Maybe Framingham test.
Yes, exactly.
Yes.
Alhamdulillah. Okay, Framingham test. We use
انا الموضوع كله جاي معايا بالشبه، انا مش عارفه الموضوع ده، انا ما قريتش عنه حاجه قبل كده اصلا.
Yes, it's Framingham test. Okay. What is the main function of the Framingham test?
It measures the age of the heart.
No. For what reason we use it?
Sorry?
For what reason we use it?
For dyslipidemia.
Measures the high risk of cardiovascular disease, especially the big age or the hypertension.
Framingham to know, yeah, to know if over 10 years the cardiovascular risk developed for the atherosclerotic patient.
Yes, you are complementing each other, Tantawi and Armia. Yes, it's for like to screen for 10 years, for the upcoming 10 years, the risk of atherosclerotic cardiovascular disease. Okay, this is the main job. of the Framingham score, okay, to assess for the upcoming 10 years the risk of cardiovascular disease. Okay, do you have any idea about the scores and the frequency? At what frequency should we retake the test or we redo the test? What about the scores?
I know the score. If you want to,
Less
I
than
think
10,
the score is
less than 10 is the low risk. Between 15, between 10 to 20 or 19.5 is medium, and above 20 is high risk.
Yes. Very good. Okay. Frequency?
Whenever needed,
The frequency for Framingham test. Hmm? Frequency for Framingham test. We said for how many years?
10.
10 years, right? So it should be repeated every 10 years, correct?
No, but during 10 years, maybe some different grades have been happening, or maybe deterioration. So I mean, 10 years will be too much.
Yes, yes. Usually it's 5 years. Every 5 years. Okay. The recommendation for Framingham test is every 5 years. Here we go. Yes. This is like the tool for the cardiovascular diseases and the risk factors. So let's talk about the treatments. We have two measures. We have the non-pharm, we have the pharm technique or pharm measures. Okay. In your perspective, which one is the most important? Is the non-pharm or the pharm technique?
unless we're talking about prevention, so non-pharm is the first choice.
Yes, I would go for that as well. Yes, non-pharm and lifestyle modification are the most important, are the most counted. Okay. Yes, we have here, and I think yes, it's like an season 2 question. Let's see if you can solve it or what. Have you heard the season 2 session? Have you heard it?
no.
No.
No? Okay, so let's do it. We have a question here. All of the following are recommended dietary regimen in primary prevention of atherosclerotic cardiovascular diseases, except A, adopt plant-based diet. Number B, increase pistachios and hazelnuts daily intake. Number C, artichoke and vegetables intake of 2 servings per week. Number D, increase potassium intake while decreasing sodium intake. Which one is wrong? Is not recommended. Not recommended in primary prevention. Yes. Sarah is saying C or D. Leah is saying C. Isti. C is yet. Sarah, C. Ziad, D. Rana, A. Okay, I cannot understand Ziad, Rana, and Noha choices. So adopt plant-based diet is not recommended to prevent the cardiovascular disease. This is strange, right? It's weird, huh? Why?
You mean he will be vegetarian, so I
So
don't think it's a good option. He can take protein or meats, but within limit.
with a limit. Okay, but there is like a vegetarian protein as well. What's the problem? What is the main reason or the main concept for which the vegetarians are adopting a plant-based diet? For what reason? They believe that plant-based diet is the best because plant-based diet represents minimal or very low risk of cardiovascular disease. This is the main idea behind the plant-based diet. Okay.
So answer is A.
No, A is correct. I'm here. We are looking here for the wrong answer. So A
Okay.
is correct. Pistachio hazelnut, correct. Artichoke vegetables intake of 2 servings per week. No, this is not correct. It should be at least 5. So 1 serving every day, at least, or at least 5 per week. Increase potassium while decreasing sodium. Of course, it's correct. Okay, so the wrong answer is C. You got it?
Okay.
تمام. ماشي. Perfect. For non-pharma technique, usually we modify the lifestyle. We're talking about smoking, alcohol, obesity, physical activity, etc. Okay, in terms of the non-pharma technique. Okay. Can we give any medications in primary prevention? Can we give or no? Let's check this question. Which of the following medication may introduce benefit in primary prevention? Tantawi is saying yes, yes, طبعا. Which one could represent a benefit in primary prevention? Aspirin, clopidogrel, estimid, brivaracetam. Okay,
Aspirin.
fine, yes, fair enough. Yes, I think all of you have answered A, which is correct, actually. Yes, acetyl salicylic acid could bring some benefit in primary prevention. There is a controversy, still a controversy for using acetyl salicylic acid, especially that it represents a high risk of bleeding, similar to the benefit it brings. So for the risk-benefit ratio, they are equivalent. Okay, we have equal ratio of the risk versus the benefit. That's why some recommendation or some evidence is for giving acetyl salicylic acid in primary prevention, while others do not recommend giving acetyl salicylic acid in primary prevention. Okay, risk of high bleeding versus risk of the platelet aggregation or the thrombus formation. Okay, they are similar. Tamam. But still we can use, yes, we can still use the acetyl salicylic acid in primary prevention, especially in which setting? In which patients?
In a patient of angina and the peripheral artery disease.
Patient of what? Angina?
In a case of the risk of high cardiovascular risk, to prevent a stroke and the myocardial infarction like that, in a patient of
Okay, in
angina
high-risk patients. Let's say in high-risk patients.
yes,
In patients with high Framingham score.
yes.
Okay, yes, we can use that. Very good. We have other options as well. Yes,
Sorry, I couldn't catch the last question. Could you please say it again?
the answer?
No, the question itself.
Ah, yes, okay. In what setting we do recommend the acetyl salicylic acid in primary prevention? For which patients? For high-risk patients.
Okay, thank you.
Recommended for high-risk patients. Okay. Very good. Yes, for high Framingham score. Tamam. Do we have any other agents that could bring benefit in primary prevention? Yes, we have. Like what? Like what?
Statin.
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 Statins? Yes. What else?
ACE,
ACE. Very good. What else?
I
ACE.
IMPA, I don't know the rest, Lita, for diabetes, has benefit for cardiovascular problem. Am I correct?
Which one?
The IMPA,
IMPA?
let
Ah,
me find
yes,
you,
yes,
you
IMPA.
mean
full name.
Empaliracana,
Yes, yes.
Yeah,
embedoglutide.
IMPA, yes. For treatment of diabetes, yes, correct.
yeah.
In diabetes treatment, yes, correct.
Not
Very good.
only Empaliracana.
Yes, Limpa, yes. Limpa, Lira, Can. Okay. And we have as well, by the way, we have as well a new evidence for the Ozempic and for Trolesti. Ozempic,
Yeah,
which
I read
is
that. Yeah.
semaglutide, Ozempic, which is semaglutide as well, and Trolesti, which is dulaglutide. Okay, there are evidence as well, evidences for both. Okay. Okay, for primary prevention, yes. So it's for diabetes treatment, it's for acetyl salicylic acid and statins, ACE inhibitors. All of those medications could bring benefit in primary prevention. Tamam? Perfect. What about ARB? Same as it. Yes. All, by the way, all antihypertensive treatment could bring benefit. Because hypertension is one of the most risk factors. If you are controlling the hypertension, or yes, if you are controlling the hypertension, you will have less and less risk to develop cardiovascular diseases. Atherosclerotic cardiovascular diseases, excuse me. Okay, good. Yes, we have here a question. Let's, yes. طيب, يلا بينا. Let's see this one. Absolute risk reductions for primary preventive pharmacological strategies in comparison to absolute risk reduction for secondary preventive pharmacological strategies. What does it mean? It means which intervention would bring higher benefit? Is it the primary prevention or is it the secondary prevention? Which one, which pharmacological treatment would bring higher benefit or impact to reduce the risk of atherosclerotic disease? Is it the primary or the secondary?
Should be primary.
Should be primary. Okay, so let's see the question, the answers. Number A, the absolute risk reduction for primary prevention are smaller compared with the secondary. Okay, this means yes, the absolute risk reduction, the benefit of the primary is smaller than the secondary. Number B, the benefit of the primary is higher than the secondary. Number C, both are equivalent. Number D, non-pharm of the primary is better than the non-pharm of the secondary.
anybody here؟
ايه نوع؟ انا سامعك.
طيب تمام، المهم ان انا مش لوحدي.
لا نوع، وانت نوع بتاعت مونتريال ولا نوع بتاعت فانكوفر؟
انا نهى فانكوفر.
اه انت نوع
كل
فانكوفر.
مره تسال السؤال ده يا ارميه على فكره.
لا ده لسه اول مره اساله صدقني.
انا
كل
حتى
مرة.
نهى وريال.
اي نهى مونتريال ردت اهي.
فين نوع مونتريال موجوده؟
ما تزعلش هغيرها.
ازيك يا نوع، عامله ايه؟
الحمد لله، ازيك انت؟
تمام الحمد لله.
واحنا كلنا داخلين نوفمبر يا جماعة ولا فينا حد مأجل؟
لا احنا ان شاء الله داخلين كلنا في 11.
نوفمبر كمان.
ان شاء الله يا رب. طب ما تيجوا كده نعمل جروب مع بعض كده، نشوف اللي احنا بناخده دوت ونعيده تاني ونحل وكده يعني.
اه
انا مستعد،
وانا
اوكي.
ما عنديش مشكله. هي نوع فانكوفر مصريه، نوع مونتريال سوريه، انا صح؟
بالظبط كده يا فندم. بالظبط،
ايوه
احنا
اصلا
المسار ونحن لبعض على طول.
ايوه. طب طب يا نوع فانكوفر، عاوز اكلمك ان انا بفكر انقل فانكوفر، فعاوز اخد رايك في الموضوع.
يا فندم تحت امرك يا فندم.
الله يخليك
اني
تعيش يا
تايم.
نوع. الله يخليك. ما انا ما اعرفش رقم تليفونك اني تايم ازاي.
I think I see you in the WhatsApp.
واتساب جروب.
Yes.
اه طب انت اسمك ايه على الواتساب؟ نهى ايه؟
نهى الخولي. انا اللي برد عليك على طول.
اه انت اللي بترد عليا. طيب يعني انت
مهم.
يعني نهى الخولي دي انت المصريه مش كده؟
يس.
ماشي انا هبقى اكلمك بقى.
هطلع لك بالباسبور المرة الجاية.
يا اهلا وسهلا. ماشي يا نهى.
هنا المشكلة باللغة الفرنسية وريال.
لا المشكله مش في لغه فرنسي بس، المشكله كمان في الشغل يا جماعه. الشغل هنا مش حلو. فانكوفر احلى والبرت احلى بكتير.
لا
أكيد.
البرتا احلى، فانكوفر مش احلى ولا حاجة. فانكوفر الفرصة فيها ضيقة قوي، انما البرتا جميلة. انا كنت في البرتا على فكرة، انا لسه جاية من البرتا من قريب يعني مفيش سنتين.
اه يا سلام.
البرتا جميلة بصراحة في كل
البرتا
حاجة.
بيقولوا جميله، شغلها
بس
احلى
هي
بكتير.
ساقعة ساقعة، شغلها حلو، انما هي بس اللي يقدر يتحمل الساقعة اتس اوكي بالنسبة لي
ده على
يعني.
اساس ان مونتريال صيف، ما احنا نفس
اه هلا عاملين زي
مجربتش.
المطر. ما
مجربتش
شفنا الشمس
مونريال
كلها
بصراحة.
الصيف.
لسه البرتا بخيرها بصراحه في كل حاجه يعني.
مهم.
اوكي. هو احنا خلصنا المحاضره ولا عملنا ايه؟
طب احنا ممكن على الجروب فكره ان احنا تراي ان احنا نحل اسئله وكده. احنا في الجروب الواتساب ممكن تراي ان احنا لو في حد عنده اسئله او اي حاجه كده وكان شات عليه
هو
ازوين.
انت هو انت اسمك
هو
ايه؟
مين اللي
هو انت
بيتكلم؟
اسمك ايه؟ ما انا عاوز اعرف مين اللي بيتكلم.
احمد طنطاوي معاكم. هو انا
اهلا
ازيك يا
طالع
بيك.
احمد، عامل ايه؟ ازيك يا احمد، انت في دبي؟
لا انا مش في دبي. انا لا، هو رقمي الواتساب لسه على دبي لان انا كنت هناك من سنه ونص سنتين. بس لا انا كندا في تورونتو في اوكفيل.
طب بصوا يا جماعه، احنا ممكن نعمل واتساب جروب بينا الناس اللي هي انترستنج ونشير الاسئله ونجاوب، لان ده مهم جدا.
انا حاسة ان
ده
احنا اصلا
بيفيد.
هم ال 12 اللي بنحضر كل مرة مع بعض، فيعني ده هيبقى مفيد لينا بصراحة.
يا ريت.
يا ريت يا ريت. انا بس خلوا بالكم، انا الواتساب جروب نمرتي على النمره المصري، فاللي هيحطني يحطني على النمره المصري.
يا فندم تحت امرك، بس احنا نعمل الجروب.
هي ايه حكايه يا فندم دي؟ انت كنت ظابط في الجيش؟
يا كبرنا
قولي لي
وصل الحمد لله.
قولي لي ارميه يا نهى.
ولا يهمك يا دكتور، ولا يهمك.
ارميه بس، ولا دكتور ولا بنت فندم ولا الحاجات بتاعتك دي؟
طب فكرني بدكتور ماجد بالظبط، بس دكتور ماجد ما شاء الله تبارك الله يعني خلص الحمد لله.
مين ماجد سعيد؟ مع ماجد
اه
سعيد. ماجد سعيد ده صاحبي، كنا شغالين انا وهو مع
ماجد
بعض في
سعيد
مصر.
ولا بس انتوا الاثنين زي بعض، بتتكلموا زي بعض بالظبط.
انا عارف. لا
Can you hear me?
يس.
يس سير.
الحمد لله على السلامة.
لا مؤاخذة.
عملنا بريك، فاصل ونواصل.
Yes.
عايزين نصلي وعايزين ناكل.
طب يلا بينا. هانت. عندكم
طب
الساعة
ناخد الإجابة بس، ناخد
هو في
الإجابة
هو في
ونطير.
الامتحان ده ما ينفعش غير الصلاه بصراحه.
ربنا يستر.
Okay.
ده رأيي.
Yes. What was your answer?
نسينا السؤال.
What was the answers? Yes, what were the answers?
D.
The non-pharm primary preventive strategy has higher ARR than the okay. Okay,
and B.
it's no, it's A. It's A. Okay. Usually the impact of the pharmacological treatment for the secondary prevention is higher than the impact of the primary prevention. Okay, that's it. This is a fact.
So
Okay.
أنا بقدر أعمل prevention للsecondary more than الprimary.
Yes.
Okay.
لأنه pharmacology يمكن.
Yeah, it's a logic. Yeah.
Here we are asking about the pharmacological strategies, right? It's not about the non-pharm. Okay. So here, and it's mentioned in the CTC.
يعني الإجابة إيه دلوقتي يا دكتور؟ What is the answer؟ إيه؟ إيه؟
A. The benefit of the primary prevention is smaller than the benefit of the secondary prevention.
يعني السكندري أحسن.
Yes, it's more impactful. It's more impactful than the primary. Okay.
طب لو غير if he change pharmacologically يجيبها non-pharmacologically.
Okay, in that case, we don't have like a comparative evidence between the two approaches.
هيكون البريفنشن بتاع
for the second prevention for the primary, I don't know because there is no evidence about that. I didn't read it at least. You can check. Okay, but
عموما النون فارماكولوجيكال I think برضه هتبقى في السكندري برضه أعلى.
we can
secondary
say
prevention.
that. We can say that, but it's not 100% correct.
Okay.
It's not 100% sure. Okay, so for the non-pharm, I cannot tell you. Okay.
But I don't understand. The primary prevention is the non-pharm, right? Non-pharmacology.
The main approach, yes, the main technique for the primary prevention.
Non-pharma. And the secondary.
What's your question? Because I think you are talking about the thing.
Yeah, because the secondary prevention, it means the patient is already has a problem and we start the pharmacology, I mean medication. So sure, secondary is the best, is better than primary.
No, I didn't understand you. You just repeated. What do you mean by the primary and secondary prevention?
Primary prevention is to prevent the disease, the problem, right? So that's why we go to non-pharmacology.
Yes.
Like lose weight and blah, blah, blah. And the secondary prevention is when already the patient has already the problem and we have to start the medication, right?
Yes, but we can recommend as well non-pharm technique in the secondary prevention. You can have, if the patient is obese, you can recommend him to lose weight. If he's not if he's physically inactive, you can counsel him on physical activity, even in diet, everything. You can still use the non-pharm technique in secondary prevention. Okay, but here we are talking about the impact of this intervention.
Okay.
Perfect. Okay, very good. Yes. Let's take this question. Afterwards, we will pass to acute coronary syndrome. For the primary prevention, it's not that, it's very simple topic, actually. Here, blood pressure reading threshold to start pharmacological antihypertensive treatment for 36 years old patient, male patient with total Framingham risk score of 17. What are the thresholds above which you have to give pharmacological treatment? Eamon is saying 160 above 100. Noha, the same thing? Okay. Rana C, Leah A, Nohadi, Ahmad Tantawi A. Armia,
Yes, sir.
which one?
I think C.
Al-Barak. Okay. Okay, my friends. So the correct answer is A,
Perfect.
as Tantawi and Leah say. Tantawi or Leah, can you explain us why it's A?
I think because of Tantawi speaking, because Framingham score is above 15, so this is according to Spirit trial that it considered as a high risk group, and accordingly the blood pressure should be less than 120 as a way of targeting. So the target to be 120.
Yes, this is what we call sprint criteria.
Yep.
Spirit trial is another trial, I think. We have a spirit trial, yes, but this is what we call sprint criteria. Do you know sprint criteria? For high risk patients, if the patient has Framingham score above 15, number one. If the patient has chronic kidney disease, what else?
If the patient is
Less
more
than 75.
yes.
And any cardiovascular comorbidities.
Excuse me?
But I remember it should be less than 120, not above 120.
Okay, the target, what is the target?
Less than 120.
Yes.
No, no. The target is reduction to around 120.
No, the target should be less than
Less
120.
than
If you
120.
want,
or
if you would,
can remember.
yes, if you would recommend a pharmacological treatment,
Yeah.
it should be 100 above 100. Yeah, it's 130, my friends. It's number B. It's not A. Here we are talking about the threshold, not the target.
We start medication or pharmacological if he is above 130, but the target is below 120.
Yes,
That's right.
yes. Here, this question is asking about the threshold. So it's above 130. It's not 120.
Yes.
So
Yes.
it should
In
be
in
B.
the baseline,
B.
if the sprint criteria, doctor, as you learn us, in the patient with the baseline systolic blood pressure above or equal 130.
Yes, exactly. It's above 130. Here we are asking about the threshold, not the target. خدتني في دوكا يا طنطاوي. But yes,
بنتعلم معلش.
لا, you got it right. I think you got
بس
almost
هي
right.
فعلا هي لو كانت جت في الامتحان بالشكل ده ولا كنا هناخد بالنا. كويس
Yes, the
جدا.
sprint criteria. No, it's what we call sprint criteria. If in this patient, because he has a Framingham score above 15, so the target should be systolic target should be less than 130, 120. So you can start medication starting from 130.
30. Yeah.
Yes, it's in the CTC, by the way. Okay, so that's it. The right answer
I
should be
can, for all the high risk patient for age more or above 75, for the clinical and subclinical cardiovascular risk, for the Framingham more than 15%, and for the kidney function from 20 to 59. And the exception is the heart failure and diabetes and institutional patient.
yes.
This is all the sprint criteria.
The sprint criteria. Okay. Very good.
انا مذاكر بس ما بحلش عيب.
Very good. Okay, Amen. Yes. Yes. Framingham score. Up to 10, it's low risk. From 10 to 20%, it's moderate risk. Starting from 20, it's high risk. Okay. Here, it's according to Sprint criteria. We're not talking about the high risk Framingham score. Is it? Yes, Sarah. Yes, it's in the CTC. In the primary prevention. Check the primary prevention chapter. You will find it. Very good. So we are done with the primary prevention. I think it was easy. It's very simple. The main approach in primary prevention is, as we said, the non-pharm technique. Lifestyle modifications, treating the risk factor, the modifiable risk factor, try to deal with the non-modifiable risk factor, or to, I don't know, like age. We cannot deal with age, but you can handle the modifiable risk factor like smoking, obesity, physical inactivity, and etc. Hypertension, and that's it. Okay. For the non-modifiable, no, we cannot modify it. So for the pharm technique, for the pharmacological measures, as we said, we can give aspirin, antiplatelets, or aspirin. We can give the statins, we can give hypertensive,
دكتور
anti-diabetic.
هو انت فين؟
يعني إيه أنا فين؟
فين السلايد اللي
أنا
شغال؟
براجع.
اوه
Yes, I'm writing. Well,
نمت بس.
yes, I'm talking about primary prevention. Yes, I'm just mentioning factors. Yes, and the screening age is important. Okay. Risk assessment tool. We talked about the Framingham score. Non-pharm techniques, as we said, very important. Pharmacological measures, other pharmacological statins, and etc. That's it. I don't think we have something to add here. Okay, yes, Sarah, we can take a break. We can take a break of 2 to 3 minutes. Then we will back to tweet corners, and I will stop the recording here.